So we are going live in 3, 2, 1. So good evening and welcome to Ortho TV UOA webinar series. And for further proceedings, I'll hand it over to our convener, Ashok Sirohi, sir. Over to you, sir.
Thank you, Dr. Ashok. Good evening, seniors and friends, and welcome to this 34th webinar of Uttaranchal Orthopaedic Association. Today, we will be discussing the plating of distal radius fractures, the technique in detail, the complications, what to do, what not to do. So it is a very important webinar about the distal radius fractures. Today, we have our speakers, Professor Kotwal sir, Dr. Vikas Gupta, Dr.Ajeet Tiwari, and Dr.Pankaj Jindal. We will be having our panelists, Dr. Gadgone from Maharashtra, Dr.Neeraj from Jhansi, and Dr. C.P. Pal from Agra. The sequence of Dr. Ajeet Tiwari is a consultant hand surgeon at Kanpur, and he will be the first speaker. He will be taking over volar plating in the distal radius fractures, in intra-articular distal radial fractures. Dr. Tiwari,
Yes,
I would request you to share your screen.
Good evening, boss.
Dr. Puneet, welcome.
Good evening, boss.
Good evening, welcome.
Is my screen is visible, sir?
Yes, your screen is visible, Dr. Tiwari.
Good evening, Dr. Ajeet.
Please go ahead.
Thank you. Good evening, Puneet, sir. Very good evening. So, can I start, sir?
Go ahead, Dr. Tiwari.
Okay, thank you. Thank you so much, sir. Very good evening, friends. I'm mobilized and my highest regards to the Uttaranchal Orthopaedic Associations and the office bearers and Ashok Shyam sir for giving me this opportunity to talk on the intra-articular fracture and the volar fixation of the distal end of the radius. This is most common fractures. Distal radius fracture is one of the most common fracture, and that is encountered by the almost every orthopedic surgeons, and they deal in their day-to-day practice. So this topic is very important to know that the all the tricks and bits of the fracture and how to deal these kind of fractures, not to miss important things in these kind of fractures. I don't have any disclosure about this. So I'll start my talk with a small case. Here's a 28-year-old young man. He's right-hand dominant. He's basically preparing for services. He had a fall on outstretched hand, and he has injury to the right wrist. He presented to me with pain and deformity. Here's the X-ray of the patients, though this is not very clear-cut X-ray, but this X-ray, he presented to me with this kind of X-ray. So if you'll see that this X-ray has intra-articular combinations and a lot of small fragments there. So it's very important to know what are the radiological parameters to know that how is the fractures, what is the geometry of the fractures. So as all of you know that radial inclination, which is around 23 degree, there's volar tilt of about 11 degree. There's a variance and the radial height of around 11 millimeter. So these are the normal radiological parameters. And other important thing is that the teardrop angle, which I think most of the people many of the people are not aware about this. This teardrop angle is important because this angle is basically, this is tangential line along the articular surface, and this is the line along the volar lip of the distal end of the radius, basically the corresponding to the lunate facet. So this angle is around 70 degree. If this angle is more, it means there is a fracture of the volar lunate facet of the distal end of the radius. Other important parameter is that the anterior-posterior distance. So this anterior-posterior distance is around 18 millimeter in the females and around 20 or 21 millimeter in the males. If the anterior-posterior diameter is more, it means there is a kind of intra-articular combination and there's kind of die punch kind of the injury has happened to the patients. So if you'll see this X-ray, all the radiological parameters are obliterated. There's a radial inclination is obliterated. There's a teardrop angle is more, and other parameters. There's a collapse. There's a volar tilt has what is the normal volar tilt has been altered. There's a dorsal tilt. So all the parameters in this radiograph is altered. So this patient has intra-articular comminuted fractures. So for the better assessment, it is advised that whenever the patient has comminuted fractures, it's a good idea to go for the traction views X-ray and the CT scan. And what literature says that the traction views X-ray and the CT scan, they are almost the similar kind of assessment is there. So if once I have done the CT scan of this patient, you can see that there's a severe intra-articular combinations, there's a dorsal combination, and you will see that there's a volar fracture of the volar lunate fragment is there on the volar aspect. And other thing is that you can see that there's a sigmoid notch fracture is also there. If you'll see that the sagittal and the coronal sections of the CT scan of this patient, there's a radial styloid fracture, there's volar lip, there's a you can say there's a rim fracture of the volar rim fracture, there's a dorsal fracture, and there's a fracture of the ulnar styloid too. So there's a classification given by the Robert and the Madoff. There's a fragment-specific classification. So why this classification is important? Because there's some crucial fragment in the distal end of the radius. And if that fragment is fractured, or if there's a fracture of that fragment, we should address that fragment specifically, because if we will not address that critical fragments, the patient will have kind of arthritis or kind of dislocations can happen. So what are the different fragments? One is the radial styloid, there's dorsal wall, there's impacted articular fragment, there's dorsal ulnar column at the die punch fractures, there's the volar rim fragments. Another important classification is given by the Rickley and Regazzoni is the columnar classification. So the whole wrist joint is divided into three columns. One is the lateral column, intermediate column, and the medial column. Lateral column correspond to the radial styloid as well as the scaphoid facet. This the reduction of this fragment or reduction of this column is important to gain the radial length, as well as the intra-articular part, both the dorsal and volar. If you'll see on there's an intermediate column. Intermediate column is basically the load-bearing column where the lunate facet is there. So lunate facet, volar side is there, the volar lunate fragment, dorsal side, there's a dorsal lunate fragment. And this part of the distal end radius is very important because this intermediate column is load-bearing. And other important thing is that there may be fracture of the sigmoid notch, and that can cause to the distal ulnar joint problems. So addressing the intermediate column is very important. Third column is the medial column. Basically, that is the ulnar head, where there's a TFCC is there, dorsal radioulnar ligament is there, and the distal ulnar head is there. So if there's because this is the rotational component of the wrist joint. So the proper is if this column is not addressed well, the patient may have the kind of distal radioulnar joint problems or distal radioulnar joint instability. So if you'll see the CT scan, 3D CT scan of this patient, you can see that there's a big chunk of the dorsal fragment. See on the volar side, there's volar rim fractures. If already there's this ulnar styloid fragment is there, and it's and the severe combination is there. So how to manage this kind of injuries, or how to manage these fractures? So there are two modes of the treatment. One is the conservative and the surgical treatment. So how to decide that where we should go for the conservative treatment and where we should go to the surgical side? So the pendulum move on which side, it depends basically on the LaFontaine instability parameters. So what LaFontaine has told that there are the 5 components. One is the dorsal angulation more than 20 degree, dorsal combination articular radiocarpal fractures, ulnar fractures is more than 60 degree. So if 3 or more parameters are present, the patient is a candidate for the surgical intervention rather than the conservative treatment. So if you'll see in my patient, what I have shown in my case, there is a dorsal angulation more than 20 degree. There's dorsal combination is there 2. There's articular radiocarpal fracture 3. This ulnar fracture is there 4. Age is less than 60 degrees. So there the 4 out of the 5, there the 4 component is positive. So that patient is an ideal candidate for the surgical intervention. So once one thing is decided that we need the surgery for this patient. So what kind of surgery? There's another criteria important. This is important slide. That's why I put it here. So there's unequivocal criteria. When the patient is unable to maintain the adequate reduction to the closed means. There's intra-articular displacement more than 2 millimeter. If there's a severe metaphyseal combination, open fracture, and when there's associated with the radiocarpal or distal radioulnar joint instability, and when the patient has a neurovascular injury, and other is the ipsilateral extremity fractures. So one thing is confirmed that this patient is fit for the surgery. So in the surgery, what kind of intervention is required? Is it closed reduction pinning or the closed reduction external fixator? Open reduction and internal fixation. And if open reduction, internal fixation, what kind of plating should be there? It is monoplate or the multiple plating or the fragment-specific plating? What should the approach, dorsal or the volar approach? So this, as there's a severe combination and there's a multi-fragmentary fractures are there. So I think this is not a candidate for the closed reduction clinic. So this patient require open reduction and internal fixation. Because if
मैं पहले दिखा लूंगी और फिर जैसा बताएंगे वो ऑपरेशन करके निकालने को कह रहे होंगे ब्लैडर को भी.
Ashok sir, can we mute this? Someone is. Okay. Yeah. Thank you. So if you'll see this, X-ray, there's a fracture on this side. There's a fracture on the dorsal and the volar side. Already I've described in the. So what kind of implant should be there? So there's a plethora of implant. There's thousands of implant available for the distal end radius, but what implant is we should use what implant and what is the ideal implant. So so the implant is basically divided in 2 categories. One is the juxta-articular plates and there's the rim plates. Whatever the implant you use, it doesn't matter. What important is that the basic science behind that should be there. So the juxta-articular, we should know that what plate is meant for what. So the juxta-articular plates and rim plates. So what is juxta-articular plate? What is rim plates? So we should know that there's a watershed line. What is watershed line? Watershed line is basically the volar rim of the distal end of the radius. So there's a pronator quadratus insertion is there over the distal end of the radius, and beyond that, that is the watershed line. Important thing is that the volar lunate fragment or the volar ulnar column, volar ulnar corner of the distal radius is present over the watershed line. So this juxta-articular plate is applied proximal to the pronator quadratus, and the rim plate is applied over the watershed line. So if you are applying the juxta-articular plate for the lunate facet fragment, this plate cannot hold this lunate facet fragment. So the juxta-articular plate is not meant for the lunate facet fragment. What happens that most of the orthopedic surgeons, what they use this traditional plates. These traditional plates, T plates are the, so these traditional plates are basically the juxta-articular plates. Juxta-articular plates cannot hold volar lunate fragment. So if this volar lunate fragment is not, there's no hold on that, it means that there's a problem will happen. What problem will happen? I'll tell you later. So we should be very clear in mind that what plate is important, where we should put what kind of plate is there. So if the fracture is proximal to the watershed line, we should use juxta-articular plate. if the fracture is at the watershed line or there distal to the pronator quadratus insertion, then probably this rim plate is important. So these are the juxta-articular plates. They are the T plates and other plates, what the traditional plates are there. So these plates are not meant for the volar lunate fragments. So these are the rim plates. The rim plates, they are important because they sit directly over the volar rim of the fracture. They are the low profile plates and they hold the volar lunate fragment. So other important thing is that what is variable angle and what is fixed angles. So what traditional plates we are using, they have the fixed angle, means that once you put the plate, you cannot change the direction of the screw. They will go in that direction only. But if you are using the variable angle plates, so these variable angles, you have the 15-degree play on the every direction. So you can direct your screw. Suppose that your plate is too distal, and you're thinking that you're assuming that your screw will go to the joint. You can direct the around 15 degree in any direction, and you can direct your screw in the away from the joint. So this is advantage of the variable angle plate over the fixed angle plates. So this is the so once we decided that we are going to plate this patient, what approach should be there? So if you're as I'm talking on the volar approach, so there's FCR approach, very well known by everyone. Once you put the incision over the FCR tendon and you find the FCR tendon inside the fascia, retract the FCR tendon medially, go in between the FCR and the radial artery, you will put the incision, you will receive a lot of fat, and after that the pronator quadratus will be there. Take the incision, L-shaped incision over the pronator quadratus, reflect the pronator quadratus, you will find the fracture site. Clean the fracture site, stabilize with the reduce it and fix with K-bias, temporary fixation with the K-bias. So how to reduce the fractures? So other important thing is that there is insertion of the brachioradialis over the radial styloid. So to restore the radial length, many a time you'll require that you have to do the tenotomy of the brachioradialis. So you have to release the brachioradialis. It is indicated basically when the fracture is more than 10 days, or when you want to put plate on the radial styloid, you have to release the brachioradialis. Important thing is that the brachioradialis is in the very close contact with the first tendons of the first extensor compartment, like abductor pollicis longus and extensor pollicis brevis. So make sure that you should be subperiosteally. You should not go more superficial, because you can injure to the tendon of the first extensor compartment. Be close to the bone subperiosteally, release it there, and then it will be much easier to reduce the distal radius fracture, because you can correct the radial length by this method. And once you reduce it, and then you temporarily stabilize with the 2 K-bias, and then you apply the plate. Why I'm so many times I told you lunate facet fragment, lunate facet fragment. Why this facet fragment is important? I'll tell you. Lunate facet is more important or more prominent volarly than the remainder of the distal radius by about 3 millimeters. So standard volar plate do not fit well over the ulnar column. So this is a teardrop angle, what I was talking about. It basically corresponds to the volar lunate fragment. So if you see that the volar lunate part of the volar ulnar column of the distal in radius has the short radiolunate ligament. And this radiolunate ligament is inserted over the lunate bone. This is very strong ligament. And once there's a fracture happens at this column, or once the fracture has happened at this corner of the distal end of the radius, what will happen that the whole lunate or the whole lunate will displace on the volar side because of the pull of the short radiolunate ligament. So this short radiolunate ligament, this fragment should be addressed, otherwise the joint dislocate on the volar side. That's why the fixation of this fragment is very important. So how to address this lunate facet fragment? Basically, if there's isolated fracture of the lunate facet fragment, you can go in between the palmaris longus and the ulnar nerve. This is midline approach. You can go in between the palmaris longus and the ulna, and there should be extended carpal tunnel approach. You should open the carpal tunnel because you should see completely this fragment. Otherwise, it will be difficult to hold because this fragment is quite distal. So complete exposure of the fragment is important. So there is a well-designed plate, the hook plate. Now it is available in India also. The hook plate is available. So how this hook plate works, there's short animation on this. You can see that there's a hook, there's a fracture of the lunate facet fragment. This fragment should be stabilized with the small K wire first. Once you stabilize, then there's a guide, there's a sleeves comes for this plate. You can put the drill, you can make a hole through the drill holes and you can apply this plate, and distally you can put this to, and because this is low profile plate, it doesn't irritate the tendons, and it gives this good stability to the fragment. There are other options also. If you have not the plates, there's called the there's a wire plate is there, and there's you can use another plate available. Sometimes you can use the screw with the washer. They act as a screw with the washer. They act as a plate basically to hold the fragment. If all these things are not there, you can put headless compression screw, Hubbard screw you can put. Sometimes you can hold with the K wires also. So important thing is that fragment should be addressed. So this is my patient which I was talking about. So as there was a dorsal fragment, and I decided to go from the volar side because there's a volar rim fragment was there. I have to adjust for that. So I went on the volar side, and through the rim plate, I hold the fragments through the, you can see this clamp, I hold the dorsal fragment because there was a big chunk on the dorsal fragment. So, and I pass the screws through the plates and stabilize and put the important thing is that how long should be the screws. What is the recommendation is that there should be 2 to 3 millimeters shorter than the, so that your screw should not pierce the dorsal cortex. It should be 2 to 3 millimeters shorter than the exactly what is required. So it should not cross the dorsal cortex, because if it will pierce the dorsal cortex, probably it will irritate the extensor tendon. So what literature says that if you're piercing the dorsal cortex and if you're the subchondral or you're under the dorsal cortex, it doesn't make huge difference in the outcome. So you can see that this 23-degree lateral views are there where the screws are well placed and the fragments are whole. So this is X-ray after the post-operative 2-week surgery. And so important thing to keep in mind during the follow-up is that FPL irritation and early implant removal. As the Pankaj sir is going to talk about the complications, so probably I'm not going to talk much about this, but these rim plates, they are very, you can say that they are very prone, they can cause the irritation of the flexor pulsus longus tendon because they are exactly over the volar rim. So there's high possibility of the tear. So always keep an eye over the FPL tendon. Check always that is it any kind of tenderness over the FPL tendon, and try to remove the implant early. So this is 1.5-year follow-up of the patient, where the fracture is united very well. All the angles, the inclinations, and the radial height, everything is maintained. And this is the final outcome of the patient after 1.5 year. So with this, I want to conclude that whenever intra-articular, always think about the fragment, think about the columns, and always address all important fragments. Because if you not address important fragments, you will land up in the complications. And correct the intra-articular steps as much as possible, and choose the correct implant according to the fracture geometry. We should know that at what place, what kind of plate is useful. With this, thank you so much for your patience hearing.
Thank you, Dr. Ajeet. The paper can be discussed by the panelists and the speakers. If anything is not clear, it was a nice presentation, Dr. Ajeet. But if there are some questions.
Dr. Ajeet, myself, Dr.Neeraj Jain.
Yes, sir.
This was an excellent presentation and very good and elaborative presentation and approach and everything. One thing I would like you to add that, there is a ulnar-spread fracture, and usually always there is fracture. So you have to appropriately judge whether to address TFCC or ulnar striate, to how we are going to check the stability of DRUJ and the TFCC operatively, because we have to ascertain it whether you address it or not address. So there are ways. I just want to elaborate you to address the various ways to test the stability of TFCC and this DRUJ.
Yes, sir. Thank you, sir. Thank you. This is very nice question. Actually, whenever there is a fracture of distal and radius, there may be fracture of the ulnar styloid. So important thing is that first of all, you fix the distal and radius, fix it properly, and then you check that how is unstable distal radioulnar joint is there, and always compare with the other side, because there are some patients who has a more laxity. So you cannot just by examining on the same side. You should always examine on the other side also. Check that how stable distal radioulnar joint is on the opposite side, and check on this side. If you feel that there is more laxity or the more instability, you can go for the fixation of the fragment, because there may be injury of the TFCC. But as this is tip fracture, so I'm not in this case what I presented. This was a tip fracture. It was not the basal fracture. So I'm not worried about, because the TFCC has two limbs, superficial limb and deep limb. Deep limb is inserted over the base of the ulnar styloid. Superficial limb is inserted over the tip of the ulnar styloid. So if base is intact, so I don't think that there's any kind of TFCC injury. But as what recommendation is that now that if there is a fracture of the if you find that the distal radioulnar joint is unstable even after fixation of the distal radioulnar joint, and even after fixation of distal and radius, you can put the slab in the above elbow slab in the full supination, because in the full supination the distal radioulnar joint is in the reduced position. One thing is you can do. Other thing you can do, that you can put a wire from the ulnar to the radius, but that wire should not pass through the sigmoid notch, because it should be quite proximal to the sigmoid notch, because it should not go through the joint. But I think what recent recommendation is that above elbow slab is enough, and there's no need of any kind of open TFCC repair. Though there are few people in abroad, they do the arthroscopy. If they find that there's a kind of TFCC injury, they do the arthroscopy and repair. But I don't think acutely there's any kind of need to repair the TFCC.
Here I would like to add one more thing, that whenever you test the stability of TRUJ, and when there is a fracture of the base and there is instability, then probably there is need of the fixation of ulnar styloid if you wish to do it. And if there is an instability of the joint and there is a fracture of the tip of the ulnar styloid, that indicates there is an injury of the triradiate cartilage.
TFCC, yes, sir.
TFCC. Then
yes,
you might need to stabilize it.
Yes.
That is the
exactly
perception.
Exactly.
Thank you. That is fine. Okay. Thank you so much.
Thank you, sir.
Dr. Ajeet, please stop sharing your screen.
Sure.
So that Dr. Vikas Gupta may be sharing.
Okay, sir.
Dr. Vikas, sir. Dr. Vikas, can you hear me?
Yeah. Hi.
Sir, you are the second speaker, sir. Please share your screen.
Yeah. Just give me a second.
Yes. No problem.
So, I'll be talking about malunited distal radius. Can you see my screen?
Just coming on, not come yet. Yes, it is there.
Yeah. So we'll be talking about most common complication, malunited distal radius. So Many people think malunited distal radius, malunion is well tolerated in distal radius. Wrist is a non-weight bearing joint. But our knowledge for last 15-20 years in the wrist biomechanics has increased considerably, And we have found that whenever there is a dorsal tilt of the distal radius, there is a compensatory lunate which goes volarwards, and that causes eccentric loading on the distal radius, which can cause articular wear. Plus, it can cause strain on the ligaments, which can be the cause of the pain. So there can be a carpal instability and late osteoarthritis after malunited distal radius. So this was like as early as 1986. Dr. Jupiter printed his published his paper that whenever step is more than 2 millimeters, there's a degenerative changes in the wrist. And another paper which was again in 1990, it was said whenever there's a malunited distal radius, there's a increased eccentric loading of the cartilage on the malunion, and which can cause arthritis. So I'll not go through the, this has been covered, well covered by the Dr.Ajeet. What is a volar tilt, length and gap, step off, stable, DREJ should be stable. So I'll not repeat that. But we must remember one thing, we should treat patients, not x-rays. So patients, elderly patient presenting late with a minimal deformity with the stiffness, give this patient adequate trial of physiotherapy, so that once you treat the stiffness, many people will become functional and they'll be happy with the fracture. So you don't have to see the just see the patient early malunion and advise surgery. But in case if patient is young and there's a deformity and displacement, those patients, because they are young, they're much more time to live by and they are very active. These patients, you should not wait and try to correct the deformity. So we'll see a few examples. But before that, we'll say what are the causes of malunion and distal radius. Many times it's a missed injury, neglected injury, or fractures which are not reduced properly by close manipulation, or during conservative management, there's a loss of reduction, or fixation was inadequate, as Dr. Ajeet was talking about, volar fragment, which can be slipped under the plate. So that is a cause of malunion. So malunion, we can divide it into two, 6 weeks, 6 to 8 weeks. That means from 1.5 to 3 months. It's an early presentation because at that time the callus is soft and fracture line is visible. So you can recreate the fracture line. So these patients, the prognosis is good, and even if fractures are intra-articular, you can recreate the fracture and fix them anatomically. But patients who present late, more than 3 months, the remodeling, especially in young patients, can occur. So in these cases, very difficult to recreate the fracture. So in such cases, corrective osteotomy is the thing. Corrective osteotomy, we can do either open wedge or closed wedge. Along with it, we have to do ulnar shortening if required, if there's a ulnar plus deformity. DREJ reconstruction if DREJ is unstable, and if our open wedges gap is big. In such cases, we must do bone grafting. We'll see the cases here. So I'll not go through the literature because this talk was more on the practical guides. So this is the common picture, malunited distal radius, dorsal tilt. So this is how you can create your tracings and correct the alignment on the X-ray and calculate the angle on tracing, and you can practically do the osteotomy and correct the angulation. So another case like this, dorsal tilt. So first thing you do is you pass your, just like any other osteotomy, you pass your wire just subarticular, and then you parallel to that, you just do the osteotomy, and then you, with that distal wire acts as a joystick, you open the wedge dorsally, and you can fix with the cross wires the osteotomy. And when you're happy with the osteotomy in AP and lateral views, then you can fix it with the locking plates. But if you're doing dorsally, we always recommend that you put small, low profile, and preferably 2 plates in different angle to give the dorsal stability Single plate, many times it fails. And if it is an open wedge osteotomy, you're correcting the length, then you should do bone graft. So these are the advantages of doing an early correction, because it is easy to get the realignment. Soft tissues are not contracted. DRUJ is not dysfunctional, so you can correct the DRUJ function also in early correction. And in early cases, you don't need corticular cancellous graft because collapse is not much, and early return to work is there. So Jupiter in 1996 said that we should be doing early osteotomy if we find patient comes early. This was a patient from Dr. Bindra in 1997. He said you must always compare the angles from other side because there are individual variation. So you should see ulnar inclination, ulnar variance, and volar tilt from the opposite normal side. So correction of malunited distal radius through a volar approach can be done in two ways: by doing an open wedge, that is a dorsal opening wedge osteotomy using a volar plate fixation. We'll throw some light on this. Closed wedge osteotomy by doing a volar closing osteotomy. And in such cases, usually we have to combine ulnar shortening with the fixation of both radius and ulnar. So closed wedge, because radius is already collapsed, when you do closed wedge osteotomy, so you have to most of the time do the ulnar shortening. Otherwise, there will be a ulnar plus deformity. So closed wedge osteotomy, ulnar shortening case like this, you calculate all your angles. Then you plan your osteotomy. You have to correct the radial tilt also. So you do the ulnar shortening. So this is how the X-ray would look like. The DRUJ is reduced, ulnar variance is corrected, ulnar shortening is done, and osteotomy fixed with a locking plate. But you can do open wedge osteotomy through a volar plate also, because you can put much stronger implants on the volar aspect compared to dorsal aspect. So it is a preferable approach for most of the surgeon to go volar in the wrist, especially for fixation. So you do osteotomy through the volar approach, standard volar approach. You do the osteotomy, and if you have to do a shortening, you can do the shortening, ulnar shortening also. That is depends on how much was the ulnar plus deformity. If you are doing an ulnar shortening, then you can use the graft on the lateral aspect in the osteotomy. This is how that graft can be used, which is resected segment from the ulna, placed on the lateral aspect. Now there is some amount of trigonometry involved. So this plate is, you can see on the model, this plate is like a triangle. You can see a triangle. Base of the triangle, the hypotenuse is the length of the plate, and the perpendicular is the length of the screw, which you have already put. So this is a well-described technique. Jesse Jupiter even published it. So this was for the standard plates. So different company, different plate, depending on screw length, you can decide what type of locking screw you use and how much correction you get. So these tables are available, or you can, on your drawings, you can use by using sin theta, the angle or distance of the screw, which will be required to correct the angulation. So once you put the plate back, you fix the plate distally on the fragment, and once you put a non-locking screw in the shaft, the osteotomy opens up on the dorsal aspect, something like this. This is showing in our same patient, which we had done an ulnar resection. Now we have used the screw, measured the height of the triangle, and you fix it distal in the osteotomy. You fix it on the distal fragment. Once you fix it, this is how you see on the C-arm. Just check the C-arm. Once you check the C-arm, you correct the radial inclination by rotating the plate towards, dialing the plate towards lateral side. So, and then you just use remove the locking screw and use a compression screw so that your plate sits well on the shaft, something like this. So this is the final radiograph of the same patient. By correcting the deformity, we use the bone graft taken from the cuff resection of the ulna. So same patient, you check for the rotation and DRJ stability in the on the just before closure. So this is the video, a short clip we have done on the bone model so that people can understand. Can you help? So sorry, I think something wrong with the video. So what we did the osteotomy. We fixed it distally into the distal fragment. This thing is done freehand because we don't want to use a sleeve. We just don't want to go into the joint, so stay away from the joint. So you tighten at least 2 locking screws. If it is an osteoporotic bone, you can use 3 or 4 locking screws into the distal fragment. And then you can remove the screw which was for the height, and then you press. Once you press, you can see opening wedge osteotomy on the dorsal side. On the lateral side also there's an opening, because what you did was you dialed your plate laterally. So this is how to the osteotomy. So this was a 19-year-old male with a dorsal tilt. So young person, you can see that there's a dorsal tilt and there's some amount of subluxation dorsally. So we opened with the extended FCR approach. Distal radius is exposed. Angles we had calculated earlier. So this is how we do the osteotomy. So their osteotomy is in the metaphyseal region so that you can get an adequate amount of purchase in the distal fragment. So this is how you judge your angle. You should be parallel to the articular surface, and then you do the plate. Plate is like, you can see the plate is fixed distally. Proximal part of the plate is towards ulnar aspect. This is a diagram side by side so that we can understand what we are going to do. So once you take the plate, you can see this is the plate now, which is not fixed in the proximal part. On the shaft, it is not fixed. And you just use single, first use your compression screw, non-locking screw. Then you can see that there's an opening of the wedge dorsally once plate sits, because there's a good amount of fixation in the distal fragment. And then you complete your fixation. Most of the time, if your fixation is good, you don't need to do a bone graft, but some people suggest that we can use bone substitutes. So this is what you can see, that there was a dorsal subluxation of the lunate before the osteotomy, and after osteotomy was opened up, the subluxation reduced, inclination is much better biomechanics. So this is what we can see on the pre-op and post-op x-rays, and this is the post-op radiograph of the same patient. So another case where there was a loss of a reduction during conservative management. So pre-op, you do the preoperative planning and do the open wedge osteotomy from the bolus side. If you have to correct the ulnar plus deformity by not doing the shortening, by doing the lengthening of the distal radius, which is many times, if it is a late case, a difficult problem because of soft tissues, but you can definitely use a lamina spreader to increase a mini lamina spreader to increase the gap, fix it. But in such cases, we always advise, especially in osteoporotic bones, that we must bone graft it. Otherwise, there's a chances of collapse or implant failure. The same patient after. So this was another case in which the compound fracture was there. You can see some amount of sequestrum is there. There's a SSC was done elsewhere. So very difficult to do a osteotomy. So it was a very difficult decision whether we should do a dorsal osteotomy or open wedge osteotomy of the distal radius. If you can see that axis of the distal radius, it's passing through the 5th metacarpal, and the soft tissues are not good on the radial aspect with the radial artery ENG. This patient had an intracardiac device plus other comorbidity condition. So we wanted to do a short procedure for this guy. So this is what it is. Like there's an ulnar plus deformity, which leads to stretching of the TFCC, which can lead to wear and tear at the lunate, ulnar facet of the lunate. So what we did is we tried to shorten the procedure by doing just a ulnar shortening procedure. So when you do the ulnar shortening, and you have to do a very significant shortening, because here the soft tissue rebalancing is done. You can see now axis has changed. It has come to radial side of the 4th metacarpal. It looks much straighter because there is a pull of ulnocarpal ligament which pull the wrist ulnarwards. So there was a restriction of ulnar deviation. That was the main cause of the deformity. So by doing a small procedure of ulnar shortening, you can get away with the much larger, much bigger procedure of resurfacing the radius and probably infected part of the distal radius where you can see the sequestrum and cavity, and doing osteotomy, chances of non-union of distal radius. So we just got away by doing the ulnar shortening. So I'll just touch upon the intra-articular malunions. They're best treated when patient comes early. Difficult to treat them when they are late, because then you cannot recreate the fractures. So you have to go more by the judgment. So here I'll just quote one paper from Penal that in 2010 he started doing arthroscopic assisted osteotomy for the malunions of intra-articular distal radius fractures. So this is how he does fragment-specific. Ajeet has already done it. You recreate the fracture and then specifically fix the fracture depending on how the malunion was there. So idea is to arthroscopically assess the articular surface whether reduction is good or not, and refix it as if you'll refix your primary fracture. So in conclusion, we'll say malunion is the most common complication of close reduction distal radius fractures, especially extra-articular ones. Intra-articular malunion results in a failure of recognition, or if there is a insufficient fixation, then there can be failure of surgical treatment also. So osteotomy offers the best results in cases of malunions, so that it gives a normal kinematics and it normalizes kinematics, which can later, if abnormal kinematics is there, later result in arthritis. So from this talk, we can say that take-home message would be osteotomies have a very reliable functional improvement if done in right indication, and especially in young patients. It requires good amount of preoperative planning. So you should know what is the amount of ulnar shortening you would like to do, what is the amount of angulation you would like to correct, and what is the length of the plate you're going to plan, and accordingly, what is the length of that screw to get the distance between the plate and shaft you're going to do. Newer techniques are there which are more precision, especially for the intra-articular osteotomies, arthroscopic assisted. And ulnar shortening is a very good option rather than going for the radial lengthening. It reduces the healing time by a lot. So if you have to do ulnar plus deformities persistent, go for the ulnar shortening rather than going for the radial lengthening. Thank you.
Very nice presentation by Dr. Gupta sir. I have two questions, one for the early malunion and one for the late malunion, sir.
Yep.
In case of early malunion, when we are receiving patient, usually they have stiffness of the wrist and finger, or sometimes, many times they have CRPS. So what is your suggestion in those patients? Should we go for initial physiotherapy and or wait for reduction of that complex pain, or should we proceed early to correct the malunion?
See, waiting for a few weeks will not change the end result.
Okay.
But in CRPS, you have to you have to wait till the symptoms are there, because you can increase by doing a surgery at that stage. Rather than improving, there can be a reverse thing. So I'll not try to go for the patients who are already diagnosed RST or muscle dystrophy or CRPS. But stiffness, definitely, you start them on physiotherapy, you plan your things. 2 weeks, you can get a good amount of, because it is already early malunion. So it is not very old fracture, like it is less than 3 months. So stiffness is not much in such cases. So you can do initial physiotherapy or surgery, because results are good when you're going early. You can recreate the fractures, especially if you're not intra-articular. Recreating fractures is very important. Otherwise, you can cause another step of, if you're doing an intra-articular malunion.
So one question for late malunion. Many times we are receiving patient like delayed presenting volar Barton fracture. So they are having complaint of restricted dorsal movement of the wrist and ulnar side pain. So what is your suggestion to proceed in such cases, because the flexor tendons are too tight to reduce the volar fragments in such cases?
So flexor tendon is not an issue. See, malunited volar Barton, what happens, it is subluxated wrist, there's a callus formation. So I'll advise you do the osteotomy, intra-articular osteotomy along the fracture. Use your curate, and here instead of locking implant, you have to have a very good buttressing. So what I do, uh, I reduce the contour of the anatomical plates so that it becomes a little bit more flatter. And once you have used a curate, the callus becomes soft and you have removed some part of the bone. So when you buttress it, the pressure is so much that you tend to get the reduction. If you're not getting a reduction, then under contour more to get the reduction, or scoop out more from the fracture side so that you can get the good reduction.
So what about your suggestion for the dislocated or subluxated DRUJ in such cases?
Which cases, volar Barton or distal?
Yeah, volar Barton, sir.
See, volar Barton, if your lip goes in a corrected position, your lunate will go back into the fossa. What happens whenever the volar Barton is, lunate comes out of this thing, lunate is volarward subluxated. Otherwise, intraoperatively, many times what I have done, I have used a fixator as well as a plate. So with the fixator, you distract it, you get the reduction well, put a plate and remove the fixator. Because you need a good amount of traction to reduce it. But not only traction, you have to recreate the fracture. Recreate the fracture, get the traction, do the dorsal, dorsiflexion. If you're not getting it intraoperatively, you can use a fixator. Your lunate should be reduced in the radius well, then only you fix your fragment. And here the fragments, the good amount of buttressing is good enough. Locking screws you can pass in, but unless you have a good buttressing, you won't be able to reduce the fragment.
Sir, how frequently you get this supination pronation in such patients, sir? If we are
There are two things. If you have reduced your DREJ, so initially supination pronation will be tight because of soft tissue contracture. So
fine, sir.
After fixation, you have to manipulate under GA, you have to manipulate this thing. And many times what I do, when I am putting a plate, the radial side, I just knock off interosseous membrane from the ulnar side. From the ulnar side of the radius, I just release some amount of you can say soft tissues or interosseous membrane or oblique ligament, and on table you get the pronation supination by my.
Vikas sir, can I ask?
Thank you, sir.
Sure.
Vikas sir, can I ask one question?
Sure.
So, Vikas sir, how do you
difficult one?
No. I'm not. So, how do you calculate ulnar shortening? How much ulnar shortening we should do that? Because it's very difficult to measure, and you know that you may land up in the positive ulnar to negative ulnar. One. Second question is that do you do the transverse osteotomy or you do the osteotomy?
I do the transverse osteotomy. If you have seen all my osteotomy, because oblique X-ray is not good because many times there can be overlap. Though people say you can do an interfragment refixation, you can get the compression. I usually get compression with the locking with the first 2 screws in a compression mode and then rest 4 screws in a locking plate. I always do the overcorrection. I'll go towards, like all my osteotomy cases, you'll see that it is a ulnar minus. Reason I go for a ulnar minus is we have seen that whatever instability of DREJ, once you do the ulnar minus, not very significant, but little bit ulnar minus, you're tightening all your ligaments, especially ulnocarpal ligament. So dorsal ulnar, volar ulnocarpal ligament, and TFCC, they become tight when there's a ulnar negative variance. So your DREJ automatically becomes stable.
Stable. Okay. Thank you, sir.
Can I also comment on this, Vikas?
Yes, sir. Please.
Hello.
Yes, sir.
You know what I do for this ulnar shortening I'm talking about? I do an osteotomy of the ulna first.
Yes, sir.
And then you try to overlap the fragments, rather to do the shortening, to bring the distal end of the ulna more proximal. And then have a look at the C-arm. How much is the ulnar variance that you want? Like what Vikas has said, you want little more overcorrection or just the neutral ulnar variance or whatever. So now, after having done this kind of overlap, then and the X-ray shows all right, the exact amount of negative or positive or neutral ulnar variance that you want, then you know how much is the overlap and how much ulna to be excised. So that actually you can make a marking on this and remove that segment of ulna.
So,
sir, is there any limit to shorten the ulna, that how maximum we can shorten the ulna? Because recently I saw one neglected Gallagher case fixed by some colleague with the simple square nail, and there was significant radial shortening, but which was infected but uniting. But there was significant ulnocarpal impingement there.
See,
so is there any limit to?
No, there's no limit. But only thing is, if you overdo it, sometimes it can be difficult to oppose the fragment. Like, because there's a soft tissue, the amount of soft tissue required. So this varies from case to case. I have done up to 5 centimeters myself, and it was difficult because you have to use a Mueller. We had to use, like, extend the incision. You had to use a Mueller compression device because we were not getting a. So don't be overzealous like you can do, because then you'll left with fixing ulna with a gap. It will be really troublesome.
There is one question to Dr. Ajeet by the one delegate.
Yeah.
When we are reducing the, as you suggested, sir, that we can extend this FCR approach up to carpal tunnel release approach. So, like tibial plateau reduction, when we are doing the reduction in tibial condyle, so we are doing some meniscal approach to reduce the condyle. So can we do radiocarpal dissection to see any step in the radius? There is one question by the faculty.
So this can be done basically for if you are using the dorsal approach, because volar side we have very important ligament. Radioscaphocapitate ligament is there, then short radiolunate, long radiolunate ligaments are there, and these ligaments play very important role in this stability of the joint. So if you really want to see that and you are using the dorsal approach, from the dorsal approach, you can see the joint. You can peep up the joint from the dorsal approach, how big a step is there. But basically, if you are going from the volar approach, reduce properly, you'll release the brachioradialis, you can correct the radial inclination, radial length and inclinations. And I think this is, it's not good idea to go from the volar side and see the joint. I don't know that. Vikas sir, what you are saying to say?
Seeing a joint in the distal radius fracture, it's a very difficult thing, and you end up in causing more damage. Though there's a described procedure, like you flip the fracture from the volar side if it is a very comminuted fracture. So you flip your cortex with your ligaments intact, then you can see from inside, like from the fracture side, then you can see dorsal part, and then you can flip it back to reduce it. Or you can use arthroscopy. Cutting the ligaments can be disastrous. Or you should rely on your C-arm.
Can I add something?
Yeah.
So, I mean, as put it in other words, there is something called as a dorsal arthrotomy, but there is nothing like volar arthrotomy.
Okay, sir.
Because all the stability of the joint is dependent on the ligaments on the volar side. So if you cut the volar ligament, you might open up, but you will have gross instability with all the carpus floating up and down. So don't cut those ligaments. If you at all, you'd repair those ligaments. There was another thing about CRPS, that's the extremely important thing that we need to know. We often mix up stiffness with CRPS. So CRPS is not CRPS, that's a stiff joint. That's like Jindal hospital here. So that's the worst way of having a stiff hand. So always see whether it is really CRPS, which is extremely rare condition. And always, if you are suspecting it is CRPS and not a stiff hand, always rule out carpal tunnel syndrome or a median nerve compression. If you are having a median nerve compression as well, address carpal tunnel, open it up, and then treat it whatever you want to do. But if you have a median nerve compression as well, it might take a lifetime to get out of the problem. Vikas, comment on that.
I think you will quote Penel also that CRPS is a myth.
Dustbin disease.
We'll not go there. We'll not go there.
No, can I also comment on this? I'll beg to differ with Pankaj on this issue. It is not that rare as perhaps it was thought earlier.
So I'll open my clinic opposite Dr. Kotwal's clinic.
It is definitely common. And the best way to differentiate between just the stiffness and the CRPS, like what you said, it is important to differentiate. And the best way to differentiate is get a radioisotope bone scan done. The radioisotope bone scan will show an increased uptake in the wrist in that area. And the good nuclear medicine specialist will be able to differentiate it from just the bone union kind of thing.
Yeah, all three phases. Yeah, all three phases, there will be increased uptake, flow phase, static phase, and bone phase. Sir has done a lot of thesis work and a lot of research. I think he has published few papers on CRPS. So it's not rare. Only thing is, very good point. We have to differentiate. Bone scan, because I think one of the thesis, the bone scan was mandatory for all the cases for diagnosis. So if I'm right, you can.
What Vikas was saying, I'll reiterate here. There's a editorial by Paco Pinal in Journal of Hand Surgery European, and he said CRPS is a, if you don't understand anything, you call it CRPS. And he has quoted further, there'll be a lot of brickbats and people are not going to like it, but it is a overdiagnosed condition. Of course, you must rule out median nerve compression in most of these situations.
Yeah, he said most of the time it is a nerve caused cause of idiopathic pain, nerve compression is the most nerve injury or nerve cause or partial injury to the nerve. But bone scan, I don't know, like maybe there was like bone scan, we could differentiate between just stiffness when there's a first phase and second phase increase uptake. If there's a stiffness, then there is only third phase stiffness. So there was a thing, because my thesis was also radionuclide isotopes. So we could differentiate in a lot of things by 3-phase bone scans.
Thank you, sir. Can we proceed further, Sirohi sir?
Yes, it was a very nice discussion. I think we should proceed to the dorsal plating by Professor Kotwal, sir.
Okay, I'll share my screen.
Yes, sir.
Good evening, everybody. I would like to thank Dr. Sirohi for including me as a speaker in his series of webinars that he has been organizing over the past few months. And this is the second in a row that I'm participating in. And I'm speaking on, as has been said, dorsal plating in distal radius fractures. Dorsal plating, the ideal candidate is this kind of multi-fragmented dorsally displaced fracture of the distal radius with dorsal bony defects. So, but this is not the only indication. Now the indications for dorsal plating have expanded, like dorsal shear fractures. Most of the radiographical dislocations, they are dorsal and they may be associated with fracture of the dorsal rim. And mind you, these are unstable injuries and therefore need to be stabilized. And then you have the displaced dorsal lunate facet die punch fragment that has been talked about by Ajeet as well. Fragment that cannot be reduced percutaneously from the volar approach itself. And of course, the centrally compressed or the impacted die punch fragments sometimes need approach from the dorsal side. The dorsal plating, also the displaced dorso-ulnar fragment, irreducible dorsal articular impaction and articular surface reconstruction that requires the dorsal approach. And again, remember that these are high energy and unstable injuries. And then if there is an associated fracture of the scaphoid, because then the scaphoid can also be approached very well through the dorsal side itself when you are doing the dorsal plating, and associated other carpal injuries. The approach for the dorsal plating would be a midline incision over the just ulnar to the Lister's tubercle. This can be a curved incision like this, or it can be a straight incision in line with the third metacarpal. Remember to must remember to avoid injury to the superficial radial nerve. You must protect it. Then what you do is you have this third compartment, that is the tendon of the extensor pollicis longus. You will release it from its compartment and bring it out and retract it radialward. Then you proceed, make an incision between the second and the fourth dorsal compartment. So the fourth dorsal compartment is the compartment of the extensors of the digits. So you will make an incision and an approach rather through the second and the fourth dorsal compartments. And this is how you do it. Now this is the tendon of the extensor pollicis longus, which has been released from its sheath and has been retracted onto the dorsal side. And then within periosteum elevator, you try to lift up the periosteum from the bone along with taking away the fourth compartment tendon. So you don't open up the fourth compartment, but you are now trying to reflect it onto the ulnar side. So you have now a direct approach to the dorsal surface of the radius without causing damage to the tendons. For reducing the dorsal angulated fractures, this is the typical, as I showed you in the first picture, the typical case where, which needs dorsal plating, and this would be the angulation that would be there. And so reduce this, the easiest way to do is to stabilize the hand like this. This is the hand side and this is the forearm side. So you stabilize the hand and put two bone levers or Hohmann retractors on either side of the fracture on the proximal fragment. So once you put the levers on the Hohmann retractor on the proximal fragment and you try to lift it up. So once you lift it up, then this angulation gets corrected. This is a very easy practical way of reducing a fracture when you are doing it by the dorsal approach. And then you have this now, you have now retracted all the tendons as I showed you earlier, and you have the dorsal surface of the radius, which you are actually free to put your plates, 1 or 2, depending upon the fracture configuration. This is the Lister tubercle. If it is coming in your way, you can even excise, chip it off the Lister's tubercle as well, so that the plate can be controlled better over the dorsal surface of the radius. This is actually a case of a double plating. That's why you are seeing the screw done from the volar side as well. The volar plating has been done first, and then it was required to go on to the dorsal side to do a dorsal plating as well. We'll talk about it shortly. Now, when you are closing this, then obviously you are covering up again the plate with the reticulum and the soft tissues which you had reflected, and then you leave the EPL outside its sheath before closure. So that means you don't put that EPL into its sheath again because it may get adherent. So you leave it outside. However, one must take care to protect the tendon, that it is, see to it that it is not rubbing off against the plate. These are the various implants, 2.4 millimeter and so on, which you can use, different shapes. They are all low profile plates meant especially for the dorsal plating. And these are the variable angle plates. They are also available, maybe not so easily or freely here, but they are definitely available for use on the dorsal surface. So this is an example of a dorsal plating, and you can see here, you may require, as I told you earlier, you may require 2 plates to put on the dorsal side to get a good reduction and anatomical restoration of the distal radius. Even for an dorsally angulated fracture like this, obviously we had seen a case done by the dorsal approach, but this can also be treated by volar plating on the volar side, provided this dorsal fragment is little large enough, which can take your the distal row of screws from the volar plate, and this has been again possible with the use of the variable angle plates. So the locking plates, I should say. So with this locking plates, you can even go from the volar side and try to get hold of them and fix them well as well. But actually that depends upon how much is the comminution on the dorsal side. So if the comminution is more, then obviously your screws, they will not hold the distally comminuted fragments on the dorsal side. And as Ajeet had said, that the screw should fall short of the distal fragment. So in an attempt to hold the fragments with your screw, you will tend to put a little longer screw, and that may cause problems as far as the tendon irritation is concerned. Another indication for dorsal plating is in the column fixation. And this has been talked about, and I often say that if more than 2 persons are speaking on the same topic, then there is bound to be repetition. So maybe the viewers are requested to bear with that repetition, or else sometimes I also say that kind of repetition is important, and therefore to drive a point home, sometimes this kind of repetition comes. So this is the 3-column theory, as already talked about by Ajeet, and I would say that the importance of all the 3 columns. Why do you need to restore all the 3 columns in plating of the distal radius? Because all the 3 columns have their own important role to play. For example, the radial column provides osseous buttress for the carpus and attachment for the important intracapsular ligament. This is what Pankaj was talking about, the importance of the volar capsule and the ligaments. Then you have the intermediate column, which provides primarily load transmission to the wrist. And then you have the ulnar column, which is actually the axis for forearm and wrist rotation. So therefore, all the three columns are important and they need to be restored, as I said just now. And also, they also contribute to a certain extent in the secondary load transmission across the wrist. So this is the example of a column fixation. You have a fracture, which is a fracture of the radial styloid. Then there is a fracture of the die punch, we just were talking about, and a combination onto the dorsal side. So this requires, there are involvement of the more than one columns, and this requires column fixation. And therefore, one plate on the dorsal side to fix for the combination on the dorsal side to correct the die punch fragment. I said that earlier in one of the slides for indications, and also another plate to fix the radial styloid fragment. There is another classification come up in an article by Peter Brink, and this is he has given a four-corner concept, which is based on the assessment, the CT-based assessment of the fracture patterns in distal radius. And according to him, there are four corners that the distal radius has. One is the radial corner, which tends to shift proximally in a fracture, and there is also maybe supination. Then there is a dorsal corner. This is the dorsal corner. This is the dorsal corner, which is actually small, and there are usually multiple fragments, combinations, which we just now talked about. Then there is a volar corner, and this is the one which shifts more proximally and volarly. And then the ulnar corner, which is actually not frequently involved, but and often disconnected from the dorsal and volar corners. And then there can be the radial, the dorsal, or the volar corners. They all can be involved individually or in combinations, as we all know, in the multifactorial multi-fracture fragments of the distal radius. Out of these corners, there is one corner which is called as the key corner. And which is the key corner? This is defined as the fragment with which the lunate goes is considered as the key corner. So the lunate actually decides which is the key corner. And therefore, the lunate sometimes gets subluxated with it, which needs to be identified. And the important point is that the reduction of the stable fixation of the key corner is the first step and an integral part of the operative strategy. So therefore, we need to identify the key corner and try to tackle that first, try to address that first. And this is actually done to avoid chronic subluxation with alteration of the entire joint kinematics. I'll give you an example. This is the fracture of the distal radius, and you can see sometimes the CT is so invaluable that it gives much more information in terms of the fracture anatomy. And also look at this. Now this is the lunate, and this is now going with the dorsal corner. And this is the dorsal side, and therefore this becomes the key corner. So now we have to address the key corner first. And to be able to address this properly, this is the case where you need to approach from the dorsal side. So once you approach it from the dorsal side, it will reduce, you can see here, once you approach from the dorsal side, this will reduce the key corner. The lunate is back into its saddle, and this has been restored, restoring the anatomy of the distal radius. And this is, can see here, 2 plates required to restore the articular surface congruity so beautifully. Another case, this is again a fracture, just the distal radius with this X-ray. It is actually not really giving you very good configuration or anatomy idea about the fracture fragments, because they can see here there is so much of overlap between the distal radial articular surface and the carpals and so on and so forth. And this is where the CT scan is so useful. You can see here there is a shear fracture. This is on the volar side. That's the volar side. And because of this shear fracture, the lunate is now going more towards the volar corner. So this is now being subluxed to the volar side. And because of this overlap, you were not able to see that fracture fragments properly in the plain X-ray. And this is the different view here. You can see here there is so much of distortion, subluxation of the lunate and so on. And now this is the case where you need to go on the volar side. And this is, you're trying to again fix the volar fragment. This is the key displaced one fragment, key corner, and you now stabilize the lunate into its saddle, and so well fixed and anatomy restored. And that's the good result that you can get. If the fixation is good, you can start early mobilization after the suture removal. The another indication, Vikas Gupta has talked about it, is for the in the treatment of distal radius malunion. So this is a dorsally angulated malunion, extraarticular. So here you need to go from the dorsal side and do an osteotomy and fix or put a plate or a dorsal plate on the dorsal side. So this is another indication for doing dorsal plating. However, dorsal plating has its limitations. Difficulty in contouring the plate to the irregular surface of the radius, technically more demanding, fairly extensive approach, sometimes it requires. The cast is required to support the fixation because sometimes the plates, they are low profile and may not really give very good support, and particularly in the osteoporotic comminuted fractures. And the scar is directly overlying the tendons and implants, and sometimes it can irritate the tendons and cause more problems. Another limitation is inability to fix the lunate fossa, and that's the lunate fossa that you all know, which protrudes volarward, and this obviously cannot be fixed when you are approaching from the dorsal side. So for that, you need to go by the volar approach. Absolute contraindication for dorsal plating being a large volarly displaced fragment. Obviously, we just a repetition that you need to go from the volar side, and this you cannot fix from the dorsal approach. Volar plating has a role. People have talked about it. Most often, it is the primary mode of fixation with augmentation by radial styloid plate or dorsal plate. Whenever you require double plating, ideally, it is the volar plate which is fixed first. So that gives a better stability, and then you decide whether you want to go onto the dorsal side or you fix a radial column or whatever. For example, here, the volar plating, therefore, is a more consensus plating because it restores the radial length and then also restores the lunate fossa. I just now talked about it. And all these two parameters are better addressed by volar plating. So therefore, volar plating is the consensus plating, and it must be done first in the order of fixation in a comminuted fracture of the distal radius. Then dorsal plating is also indicated whenever you are doing double plating, volar as well as dorsal plating, and there are limited indications in division cases and in comminuted fractures. Then this is how you, of course, this has been talked about. I'll not repeat on this. You go from the volar side, fix the volar plate, and then you go onto the dorsal side and fix the dorsal plate. The volar plate is required. The volar approach is required for displaced intermediate column fixation and the rotated radial column or radial styloid fragment fixation. The dorsal approach is required for the displaced and unstable dorsal fragment with central impaction. This is basically for the intermediate column. Yes, this is another case. This is you can see here multiple comminuted fracture with this kind of deformity, and this requires both the volar plating as well as the dorsal plating to get such good restoration of the distal or radial surface articular anatomy and good function after about 2 to 3 months. This is one case we had. This shows a comminuted fracture here, and you can see here, this is the dorsal fragment, and this is the key corner. The dorsal, the key corner, the lunate is getting subluxed dorsally. So we decided to go on from the dorsal side. So as we tried to fix on the dorsal side here, and then we needed a radial plate as well. And then eventually we thought that, that is not good enough. There was the combination on the volar side was not being addressed. So we ended up putting plate from all the 3 sides, but restoring the anatomy so well. You could actually now hardly see the fracture fragments as well. And this is the ultimate union. And this is not the usual practice that I would do, but sometimes to restore and depending upon the fracture configuration, you may have to resort to that. And this was the function of that patient: a healed scar and no deformity of the distal radius here. And I agree that the volar this thing is limited, but the dorsiflexion is definitely fairly good. The complications of dorsal plating would be adherence of the extensor tendons, which will lead to stiffness, implant failure, malunion. The implant failure may happen because of the osteoporosis, malunion, and extensor tendon ruptures. About the extensor tendons, a lot has been talked about in the previous literature, because the plates cause the tendons here. But now that used to happen with the earlier plates. Now it was common earlier, but now it has been reported that there are no cases now because the plates are low profile, and there is so many references which claim that they have not seen any case of tendon ruptures after the dorsal plating. I came across a case about 2 years back, and this was operated elsewhere with a dorsal plate, and the patient had drop of these 2 fingers. And when I opened it on the dorsal side, you can see here these 2 tendons are intact, the extensor digitorum communis, whereas these 2 tendons were ruptured because of the plate here. And I used a tendon graft to bridge the gap between them. This is the extensor compartment, 4th compartment exposed. This is the retinaculum after the tendon grafting is done. And this is the importance. I showed you that, you remember this slide. This is the importance of lifting of the periosteum along with the 4th compartment tendons. If you do that, then perhaps this is not likely to happen. But if you violate the compartment, then this kind of complication may occur. And then after the tendon grafting done, then this is the retinaculum closed, not too tight, so as not to cause adhesions. And maybe you can also do a little Z-plasty here, so that it doesn't become too tight. And this is the result. This is the healed scar. The patient can make a full fist, and then this is the complete extension, no finger drop. Another just a closing slide about this, about the importance of initial radial fixation on the volar side. If you don't do that and fix the dorsal plate first, then this may happen. This is a good example that's elsewhere. Loss of radial length, because the volar plate restores the radial length, I showed you earlier. Then the loss of the perfect curve, and then can be also because of the length is not restored, there can be negative ulnar variance. Just a word about the distraction plating, which is done on the dorsal side. Although I have no experience, personal experience with this, but this is in the literature, and this is also very recent articles. And this is what they do. If in a very severely comminuted fracture here, you would do a dorsal plating. Don't bypass the fracture and just put the screws into the metacarpal and the distal radius. Keep it for 3 months, and then you remove the plate after 3 months, and this leads to good results. And this is a very recent article, 2019, and the use of dorsal distraction plating, and it was a meta-analysis of 8 studies, excellent outcomes reported, very low complication rate, and they definitely they showed advantages over the volar plating. Of course, the only flip side is that it requires plate removal. So is it just the surgeon's preference whether to do a volar plating or a dorsal plating? No. According to this article in 2015, in the Journal of Wrist Surgery, this is again about, does the complication rate help us to choose whether to do a dorsal plate or a volar plate? So it said there's no preferred plate fixation technique. The decision should be based on the fracture type and the surgeon's experience with the specific approach. And of course, the bottom line is the correct decision to do that. Thank you very much for your kind attention.
Thank you, sir.
For a nice presentation.
Dr. Kotwal, may I ask a question to you? Dr. Neeraj Jain here.
Sure.
Sir, actually, there's something different which was actually we have not covered till that 2-3 question two step of the question is there in my question. That is, first is in acute situation, how you diagnose and manage the scapholunate disruption along with the distal radius fracture. That is first part of the question. First part. And second part is, suppose as an orthopedic surgeon treated a distal radius fracture, good union has been done, everything was fine, but after some time we see there is a DC deformity. So in the late stage, how you manage this DC deformity with the distal radius, and how you manage the, in fresh cases, the scapholunate ligament disruption?
Good question. The associated soft tissue injuries along with the fracture of the distal radius, as per the literature, they have been reported to the tune of about 40-45%, which includes these ligamentous injuries, injury to the median nerve or whatever. So this is definitely an important point, and actually you should be able to suspect it, a scapholunate dissociation, if on that X-ray you see an increased gap, a little increased gap. It may be very subtle gap. It may not be like a classical Terry Thomas sign. A very subtle gap increase. If you suspect that, then you may get an MRI done, or that is why people do, like people like Vikas, Gupta, they do orthoscopy, assisted fixation, so that they will diagnose those associated soft tissue injuries. And for an acute scapholunate dissociation, the treatment is relatively easy. After you have fixed the distal radius, all you need to do is to reduce the scapholunate by manipulation and put a K-wire going from the scaphoid into the lunate. And that K-wire you can keep for about 3 to 4 weeks. That is good enough. That is going to reduce and heal the scapholunate ligament injury, and generally it doesn't require anything more than that. This is as far as the acute injury is concerned, if it is diagnosed in time. That's number one. For the late diagnosed scapholunate dissociation with DC deformity, this is actually a technically demanding problem, because that depends upon the stage. That what is the stage and what is the status of the articular surfaces and all those things, whether it can require a ligament reconstruction, cannot repair the ligament, whether it will require a ligament reconstruction, or whether it will require proximal rocarpectomy or tendon reconstruction, all those things. So that is a little this thing which cannot be talked about in just one
Tough situation.
Yeah.
Thank you, sir. Thank you very much.
Sir, what is your usual time to remove the dorsal plate?
People generally would advocate removing after nearly about an year or so. Once the fracture has healed very well. That's the time, and actually that also is recommended only for the reason that because this may cause irritations of the tendons and problems with tendon ruptures and so on.
Sir, what is your distal limit to put the dorsal plate? Because there are dorsal grooves for the tendons. So how distally we can put the plate on the dorsal rim?
See, dorsally, generally there is a lot of comminution, and you need not go really very distal to enter into the joint, because the dorsal plate can also act as a buttress plate. So if that T or L limb of the dorsal plate is able to buttress your fracture fragments, that is good enough. So you can even get away by just putting one screw into that distal horizontal limb and 2 or 3 screws in the proximal one. So you should be careful and not enter the joint. But and obviously the advantage is this can act as a buttress plate as well.
So one of the biggest complication of the dorsal plating, as I did, sir, the wrist stiffness. The many patients are 2 or 3 cases I did, but the bigger complication is the wrist stiffness. Are you having any suggestion to?
No, I would suggest that I would actually, after the dorsal plating or this thing, I would put the limb into a slab, EOP slab, just for about 3 to 4 weeks, depending upon the kind of fixation that I achieved. on table, and after that start with guarded mobilization of the wrist. That is, I think, the best thing to do.
Thank you, sir. Thank you.
Thank you, sir.
Thank you.
Our state president, Dr.IM Singhal, is also there today.
Good.
Welcome, Dr. Singhal. Can you hear me?
Yeah, I think he's left, sir.
Just left.
Just
He was
left.
there.
Yeah.
Okay. So should we move on, sir?
Dr. Pankaj, sir, I think.
Yes.
Dr. Pankaj will be dealing with the complication section.
Okay, sir.
Can you see my slide?
Yes,
Yes,
sir.
sir.
Okay. Good evening, Professor Sirohi, Uttaranchal Orthopaedic Association, for this opportunity. Complications, the topic is usually given to the one who creates maximum complications. So I am here with you to talk about complications here.
Yes.
And as it is a slide, okay. The complications can be many. Infection is the most dreaded complication, together with ruptures of various tendons. The most common being, can you hear me? Okay. The rupture of extensor pollicis longus, extensor indicis proprius is one of those. Extensor pollicis longus, extensor digitorum communis, flexor pollicis longus, screw penetration into the distal radioulnar joint or radiocarpal joint, loss of reduction, especially the volar ulnar fragment, about which other speakers have contributed a lot. Malreduction, if you don't reduce it properly, and you end up in a bigger trouble. Nerve injuries, from cutting the nerve to compressing to nerve and pithing the radial sensory nerve, are some of the various complications. Let's talk about the infection. The one that is absolutely avoidable is opening up the instruments and everything before the patient is wheeled in here. Once the patient comes, he shifts to trolley, all the dust that percolates into the room, it's settling on these instruments, and therefore these should not be opened. At least that's the protocol that we follow. Don't open up everything before the patient has been wheeled in here, has been covered adequately and completely here. And you see everything has been opened up and the patient is still to come in and is all draped up here. This is absolutely no, because that you're going to raise all the dust here. And you see he's all prepared here, and see all this thing. The moment this lady swings here and there, she's going to swing all the dust into the room, and that's what we practically always avoid here. And you see this is an absolutely no. This is an internal fixation going on here. And this gentleman goes everywhere into the city here with this dress here, and all the dust is coming from the fan onto the field here. And this is again an absolutely no to avoid any contamination and infection here. Coming to the tendon rupture here, so something has gone wrong. And anyway, tendon rupture is again not uncommon. Yes, it is going down because of the uses of thinner plate, but what can possibly cause rupture of the tendon is the drill beats and longer screws, and therefore longer screws are to be avoided. If you are using a volar plate, avoid screws going onto the dorsal cortex, otherwise you can have a problem. And similarly, the drill bits crossing the dorsal cortex, they can rupture the tendons here. Extensor pollicis longus tendon is a possibility. If you have a rupture of the extensor pollicis longus, a good option is to harvest an extensor indicis proprius, which is the ulnar of the two tendons here, cut it here, deliver it onto the wrist here, reroute it and bring it to the extensor pollicis longus here, and suture it to the ruptured extensor pollicis longus here, and you can get a good healing. And you see with these 3 short incisions, you can have a transfer here. Another complication is with percutaneous fixation. This happens if you are not dissecting the nerves and separating it, and without making an incision, you are passing your wires. And then also you can cause damage to the nerves. If you have ended up damaging the nerve, if you identify the problem, you can do a primer repair. In this case, some slide has been missed. I have put in a vein graft here. The third complication that you can see is a malunion here. This was a gentleman who had a plating earlier, but it went on to a shortening of the radius, and now he presents with snapping of the wrist. Though the shortening is not significant, the plate has been removed, but the snapping of the wrist persists here. And what you see here, the lunate is sitting on the dorsal edge of the radius here. So we decided to do an osteotomy. The idea is to do a distal fixation first, followed by osteotomy, remove the plate, and now distract it here. A good instrument here is a laminar spreader here, to which Vikas Gupta was mentioning here. You do an osteotomy here. Now, a good option is fix it distally. Now use a laminar spreader, and now do a proximal fixation here. So this is what we achieved here. A possibility here is affection of the distal radial nerve joint in this patient. So patient should be forewarned that you can have restriction of pronation supination, and you might possibly have a secondary surgery for correction of the pronation supination if there is a problem here. So this was the preoperative procedure photograph of the gentleman here. This was the amount of shortening, and this was after lengthening. This is what we see preoperatively. The lunate was sitting on the dorsal rim here, and here the lunate has been centralized here. We called the patient the other day for getting a fresh review, and to our good this thing, his father said he has joined in Air Force. That means the amount of restoration of function was almost 100%. Otherwise, there was no way he could have joined these elite forces here. A screw can end up into a joint. This I picked up from the journal here. This happens if the patient after surgery has restriction of pronation supination, pain, or snapping here. A plain X-ray may not be able to pick up this thing, and these people require a CT scan to identify the problem. Once you have identified the problem, remove this single screw, and the patient's pronation supination can be restored here. This was yet another patient I picked up from the journal here. Here the radial column, the fracture fragment has subsided, and this has to be restored because this plate is not serving the purpose. You see, this is a proximal migration here, there is a proximal migration here, and this requires a revision surgery here. The problems can be because of hardware itself. This screw, this tension band wire was prominent under the skin, and this had to be removed after the healing has been completed, which means about at least 2 months to 3 months, when at least this tension band wire can be removed here. This was yet another boy, skeletally immature here, had a fracture of the distal radius here, and this was a fracture. It has been fixed with a K wires here. This has been with a pediatric orthopedic surgeon to start with here, and he has been adequately followed, and it was concluded the X-ray after the healing showed excellent recovery here. But after 2 months, what we notice here, the epiphysis is almost at the same level. At 2 months, there is some amount of shortening, though not too major here. But what happens after 6 years? This is the unaffected side. There's a significant premature epiphyseal closure here, and the radius has become significantly short here. And therefore, be extremely wary of passing the K wires through the open epiphysis. And if at all you do an early removal and follow up these children for a pretty long time till the epiphysis has, till the skeletal maturity has occurred here. So after 6 years of this excellent results, what we notice, he has pain, he has restricted range of motion, and he has a prominence of ulna and deformity here. And therefore, be extremely careful of this wires passing from the open epiphysis here. We did an osteotomy, we did a lengthening, but this is the amount of lengthening we have achieved here. We couldn't do further because of the abnormal sigmoid notch of this gentleman here. He might end up in a second surgery if at all he has a restriction of pronation supination. I have not seen him lately here. For almost 1.5 years he has been away. Let's hope to see how he's doing as far as pronation supination is concerned here. This another gentleman for the fracture of the distal radius. We see a PA view here. The inclination is good. What about the lateral view? This is the pisiform, which is posterior to the flare of the scaphoid. The metacarpals are overlapping. That means this is a good lateral view. But on the lateral view, what we are seeing? On the lateral view, you must see the superimposed shadow of the radius and the ulna. But ulna is not superimposed. That means something is wrong with the ulna here. What happened? The ulna is subluxated. It is dislocated, in fact, here. So what was respectfully seen was only the PA view and not the lateral view. So if you miss something on the lateral view, which is the distal radial nerve joint instability or subluxation or dislocation, you can have gross loss of pronation supination here. He came after almost 1 month here, and there was affection of the distal radial nerve joint of this thing. What we notice here, the ulna is gone with the dorsal fragment here. And therefore, what he required was not the reduction of the ulna, but if you reduce this fragment here, the ulna will automatically fall in position here. So we went from the dorsal aspect here, put in a plate here. Yes, we could have gone more ulnarward here, but this is the fixation we obtained. We were doing redoing. So we temporarily put 2 KYs after this fixation, because we just wanted to be doubly sure that everything is going fine. After this reduction here, we put in 2 KYs for 3 weeks here, immobilize him in above elbow supine plaster, and after 3 weeks we remove this plaster, we remove this thing. Did it help? It went on to good healing here. And this is a kind of pronation supination and flexion extension of the wrist that we got here. Coming to another patient with premature epiphyseal closure as a complication of this. This presented much later. He had almost 4.5 centimeters shortening of the radial side of the distal radius. His DRUJ was maintained here, and if the problem was only on the radial column and not on the intermedial column here, and therefore we decided how we can do an osteotomy only on the one side, and we use a fixator. So what happened, to recapitulate the story, he had a K-wire. There was a premature epiphyseal closure only on the one side. Epiphyseal block was formed here. So this continued to grow on the intermediate column, but not on the radial column here, and ended up into this kind of a problem here. We use external fixator and use a pivot on the intermediate column so that we lengthen the radial column and not the intermediate column. So this was maintained here, and only the radial side was lengthened here. We did, in fact, the over lengthening here, and they did an osteotomy here so that we could restore the radiocarpal joint, maintaining the radio-ulnar joint here. So this was the fixator we had here. This was the overlengthening that we achieved here. Initially, we wanted overlengthening because shortening was easier. This was the correction we got at the radiocarpal joint here. I didn't put a fixator across the carpus. Therefore, we got some fusion here of the radius with the lunate here. But this is where we began. And this is where we ended up. Did it help? Yes, this is the kind of pronation supination and flexion extension we got. Extremely good pronation supination we got of this patient here. This was a girl who had a shortening of about an inch of the ulna. Now I knew she's from a far off place. The follow-up is not going to be very easy, and therefore it was probably more prudent to do a shortening of the ulna rather than lengthening of the radius here. Sure enough, she had, this is the amount of shortening she had of the forearm here, and this is the restriction of pronation supination she had to start with here. And therefore, I opted for shortening with ulna because I knew the follow-up is not going to be easy. She lives far off here, and I preferred to use a fixator rather than a plating here because I knew I can do more and more and more of compression of the ulna if I require, because I knew with more compression, I would not have a possibility of a non-union here. Yes, the ulna is relatively longer here, but let's see if that really is going to be detrimental for her pronation supination here. So this is where we began. This is the shortening that I achieved of the ulna here. After 4 years, this is the kind of course, the shortening is there, but pronation supination, yes, we were able to get a good pronation supination. The scar is limited here, and that ulna which was prominent has disappeared here. Flexion extension is good, and pronation. So ulna shortening is a good option in this patient, as I've shown with the follow-up here. A very important point here is this fragment here. So again, to which other speakers have mentioned here, the volar ulnar fragment here. This patient had a plating earlier, but what happened? This fragment was missed. In fact, this patient had this wire was, this screw was holding this thing, but it lost control and this settled here. This purchase was lost here. And therefore, he presented again with loss of pronation supination here. So this is the fragment that we are talking about, the volar ulnar fragment. This purchase on this fragment was lost. There was no purchase. Probably if this screw was put into this hole, probably this would have not happened. And therefore, be extremely respectful for this patient with the ulnar volar fragment fracture here. So this is where he presented with loss of pronation supination here. There is no purchase on the volar ulnar fragment here. We got a CT scan here, metacarpal, capitate, lunate, and the whole fragment has collapsed and telescoped here. And therefore, the idea was the plate is holding only the radial fragment and the ulnar fragment has no purchase here. And therefore, the idea was how we can redo this surgery and move this plate more ulnarward here. You see the whole corpus has also collapsed volarward here. So we decided we'll do an osteotomy. After removing the plate, we could see a more anatomy of this fragment on the ulnar side here. We did an osteotomy here, and this is how our 4 mm, 6 mm, 8 mm, 10 mm osteotomies were used. And this is the diagrammatic representation through this model here. And we did an osteotomy of this fragment here. Once this fragment had been freed here, don't free it up on the volar side as has been elucidated earlier here, because these are extremely important ligaments. Whatever ligaments are available here, don't cut them here. Cut the fragment and free up this fragment and distalize this fragment here. Once you have the fragment located and the restoration of the joint line has been done, press it here and put 2 KYs temporarily here and now put a plate there. See to it the first screw goes into the ulnar fragment. Try to have at least 2 screws, at least 1 screw, 2 screws will be ideal, and have a purchase and then put your plate screws onto the radial fragments here. So this is where we began and this is where we ended up with screws. We had 2 screws on the ulnar fragment here. So we had 2 screws on the ulnar fragment here, and sure enough, it serve the purpose here. There are a lot of articles on this thing. I'll skip these things here. Coming to another thing about the external fixator and the complication with the external fixators. There are not a lot of ligaments holding this fixator. There are ligaments on the radial side, radioscaphocapitate, long radiocapitate, long radiolunate ligament, but there are not many ligaments here. And therefore, if you put a fixator, which works on the principle of ligamentotexis, there are no ligaments, and therefore this tends to collapse. This was the screw, this was the place where the external fixator was put. It still continued to subside, and therefore this required a revision fixation. Instead of going through a standard flexor carpi, to have a good fixation, we went ulnar to the flexor tendons. Between the ulnar nerve and the flexor tendons, we had a good view of this thing. We could relocate this fragment and put a plate there. And coming to the last one is the osteomyelitis. This gentleman had a plating here, and there was the discharging sinus here, and this is the disaster now. A good option that I have found is instilling methylene blue. The moment you put in a methylene blue, everything in that is blue and sinister looking is removed, then that's a very good way of removing all the dead bone from there under tourniquet. And once all the dead bone has been removed, methylene blue is the good trick. You do an extremely meticulous debridement after extending the incision, and it is not just a debridement through a window. Again, it is not tissue culture. It is a tissue culture, it's not a swab here. And antibiotic use is not empirical. Involve respectfully an infection disease control specialist, because he's going to bail us out of this disaster that is in front of us here. And therefore, involve an infection disease control specialist to control the problems here. Once this dead bone has been removed, the radius appears to be in place, but we knew we are heading for the trouble here. And sure enough, the radius started to subside. And now we can't have it, otherwise the whole carpet is going to collapse as well. And therefore, We went in and put a fixator to keep the radius hoisted up and maintain the radial ulnar joint here. Once the infection was under control, we put in a fibular graft here, but we kept the ESR was under control. Then only we put in our plate. We had a green signal from the infection control doctor that you can go ahead and put in a plate. And we put in a plate here. And did it heal? It healed, and while it was healing, he had a second fall. He had a second fall. But we removed the plate. Did it heal? Yes, the wound healed. He had a good pronation supination. He had a reasonable flexion extension. It was not full extension, full flexion, but he was happy with a healed wound, no infected wound here, and good pronation supination and functional range of motion he had here. So this is where we began. After debridement, this is where we were with the radius collapsing here. External fixator saved us from the trouble here, and then fibula grafting here. It went into non-union, but this non-union was asymptomatic. Though it was a hypertrophied, being asymptomatic, he had a good range of motion. We stopped the treatment at this point of time and said, okay, see if you have any problem here. So we talked of complications. This is extremely important. Once you do have a carpal tunnel, once you have CRPS, see to it you don't have a median problem here. The most important thing to avoid stiffness is to have an extremely good hemostasis and elevation above the heart level. Keep moving the fingers all the way up, all the way down. And I encourage the patient to take his shoulder up every half an hour, all throughout his waking hours. Otherwise, you can have a lot of stiffness. Encourage movement from the first day itself and keep encouraging movement. See to it you are able to flex your metacarpophalangeal joint from day one. See to it you are able to extend your interphalangeal joint from day one. Spend 10 minutes, 15 minutes, 20 minutes. See to it you are able to do it. Instead, give him a splint so that he flexes his MP joint. See to it he extends his IP joints. Otherwise, you can have problems. And involve therapists or put in efforts to do this movement early. Otherwise, you can have a lot of stiffness here. So in summary, majority of complications are avoidable. The fact that you know that they are likely to happen, you look out for them. If you look out for them, you can avoid these problems. You can avoid tendon ruptures because they are preceded by pain along the tendons. They are preceded by swelling. They are preceded by synovitis. Once you see you are seeing problems, look into it, take out your implant or screws, offending screw, and you can avoid a tendon rupture. If at all you see a tendon rupture, of course, tendon transfers help you overcome the problems here. If you are seeing a malunion, restore height, look at the ulnar corner, volar ulnar corner, and respectfully fix it. Otherwise, you can have a carpal collapse here. And of course, you have options of osteotomy and look at the ulna as well. If you have a radial collapse, you can do an ulnar osteotomy and shortening of the ulna for an early recovery. I thank Dr. Sirohi. I thank UTTARANCHAL Orthopaedic Association for patient listening. Thank you once again.
Thank you, Dr. Pankaj. Talking of complications in such a systematic manner and handling each of it, still there may be some situations where the complications may remain complications. And Neeraj is going to ask something. Yes, Neeraj?
Yes, sir. It is perfect, sir. I was congratulate Dr. Jindal. It is such exhaustive, and there is nothing to actually. We have to prevent complication. Best way to tackle complication is to prevent the complication, as Dr. Jindal said. Much easier to prevent than to treat them.
There are 3 grades of complication. Grade 1, my complication which I can treat. Grade 2 complication, that I create complication, I send it to you and you get corrected. And grade 3, neither I can solve it and nor you can solve it.
Sir, Dr. Pankaj, sir, can I ask one question, sir?
Sure.
Yeah, sir, what is the feature of soap Paparji and this direct procedure like thing, sir?
Direct Savakopanji is an extremely good option. There are various types of Savakopanji options which are described, and it does miracle in restoration of pronation supination if distal radial ulnar joint has become arthritic and you cannot get pronation supination. What I have been doing, and it's slightly different, is I don't fuse the distal radial ulnar joint. I do a minimum dissection without causing damage to the sensory branch of the ulnar nerve here. Minimum dissection to the periosteum, and then take out about a centimeter of the ulna and do an early pronation supination. So we get a pseudo joint of the distal radial ulnar joint, and we get further movement at the sleeve of ulna that we have excited. But because the periosteal sleeve is minimally damaged, the stability of the proximal fragment is also respectfully saved. So I don't put a screw across the distal ulna into the radius.
Because sir, many times in malunited distal radius fractures, the patient is complaining of ulnar side pain. So I think we should focus on maximum time.
Should have mentioned that thing.
Yes, sir.
Okay. The ulnar sided pain, it's a vast topic. The one thing that is extremely common in malunited distal radius is the ulna becomes relatively long. And the ulna then impinges onto the triquetrum or onto the capitate, which is called as the ulnar impaction syndrome. I should have covered it. I missed it.
What do you think, sir? Should we come to the end of the webinar?
Yes,
thank you, Professor Kotwal, sir. Thank you, Dr. Vikas. Thank you, Dr.Pankaj. And thank you, Dr.Ajeet. Dr. Puneet will be formally thanking on behalf of our Uttaranchala Orthopaedic Association.
Yeah, thank you. Thanks to all. Thank you, Dr. Pankaj sir. Thank you, Dr. Kotwal sir, Dr. Gupta sir, Dr. Tiwari sir. Thanks, Dr.Neeraj sir, Sirohi sir, Ortho TV team for a wonderful event, for a wonderful webinar. Thank you.
Sir,
good night.
Sir, I want to put special thanks to Dr. Ashok Shyam. He has been so cooperative, and he has been doing wonderful work for us, for the Uttaranchala Orthopaedic Association, and especially for me. Thank you, Dr. Ashok.
Thank you, sir.
Ashok sir, thank you, sir. Ashok Shyam sir,
Thank you. Thank you.
Thank you, sir.